And many of my patients have asked me to put out a brief presentation about some of my before and after top surgery results. I live in Cleveland, Ohio, and I'm in private practice and also affiliated with Case Western Reserve Medical School. And this is going to be a talk about gender affirmation top surgery for a masculine appearing chest. My practice. I've been performing chest masculinization surgery since 2002. I was in academics for 17 years before entering private practice 8 years ago. In the last 10 years alone, since I've been keeping careful records, I have performed around 2,000 double mastectomies. My career total is now more than 3,000. The majority of my patients do not live in Ohio, and I frequently operate on patients from other countries, including Australia, Israel, India, and China. I've chosen to limit my gender practice to 100% outpatient surgery. No one gets admitted, and out-of-town patients, unless they live within driving range, typically spend about a week in Cleveland. This model has worked very well, and it is extremely rare to have a distant patient with a problem that needs to be referred to a local doctor. My situation is not ideal because I'm a solo practitioner, but my philosophy is to always be available for consultation via phone and the internet. I constantly evaluate new patient pictures and histories and follow distant patients via the internet and emailed photos. My office answers patient calls 24/7. There's no answering service. My nurse is always available. The reputation that I have built has taken 20 plus years, and my patients mostly find me through the internet. There is a lot of different internet resources. If you do not know about this one, transbucket.com. This is a free site where patients post pictures and discuss their surgeons. Dozens and dozens of my patients have posted their results, and I have no control over what they post. You can look on Instagram, you can look on YouTube, and hundreds of my patients have posted about their results of me. And again, I have no control over what they post. For my practice, I do require a therapist letter stating that all my patients meet the standards of care and are ready to proceed with this irreversible and life-changing procedure. I do not require testosterone, but most of my patients are on it. My BMI cutoff is 45, and this is per anesthesia outpatient protocols. 100% of my surgery is outpatient. The surgery takes between 1 to 2 hours. 100% of my patients get something called the tumescent technique, which is a lot of local anesthesia infiltrated into their chest, and this enables me to also do chest liposuction. 100% of patients get drains. I know it's annoying, but I find that they are still very useful. 100% of my patients get foam on their chest covered by a compression vest, and this stays on until follow-up. I operate on Tuesdays and Wednesdays, and my patients all come back on the following Monday. At that point, the drains are removed, dressings are changed, and the patients can start to shower. I do have them wear the vest for a total of 2 weeks. There's 2 basic operations for masculinizing top surgery. There's the peri-areolar procedure, which is about 22% of my practice. And this can be a complete circumareolar incision with a purse string mastopexy, which means tightening of the skin down to a smaller nipple areolar complex, versus a keyhole incision, which is just a partial incision around the areola. Or I can do a DI, which is a double elliptical incision mastectomy with free nipple grafting. The nipple and areola are either grafted together or separate. I do not use things such as wise pattern or pedicle techniques. In the last 10 years, I have never given anyone a blood transfusion. I've never kept anyone overnight. No one has ever been readmitted for IV antibiotics. My hematoma rate, which is a collection of blood under the skin, is now 1%. In the last 6 years, I've never taken a patient back to the OR for a hematoma. So, peri-areolar surgery. Typically, this is for A to B cup patients who have good skin tone. This preserves nipple and possibly nipple sensation, but not always. And the scars are confined to around the areola. In a complete circumareolar peri, I will take away some of the skin surrounding the nipple. You can see here, it's the de-epithelialized skin. I'll then make an incision through that de-epithelialized dermis, take out tissue. I then close that incision and then close the outer diameter circle down to the inner diameter nipple and areolar complex. And you can see that you get this bunching up of tissue, right? And this is what's called a peri-areolar mastopexy. This is a patient who had this before and after. And you can see that there's a little bit of distortion of the areola, but in general, this is a good result. Here's another patient. These are pictures provided by the patient. So unfortunately, the nipple and areola is not visible in the pre-op picture. But you can see post-operatively, here's the patient with the purse string mastopexy 2 years out. He's also done a lot of working out, as you can see. Here's another patient who I really think is borderline. There's a fair amount of volume and a well-defined inframammary crease. And this is a person who I might just as easily have decided needed the double incision surgery. But I agreed to do the peri-areolar procedure with the purse string mastopexy. And here the patient is in a couple weeks. And you can see there's some rippling and bunching of the skin. So it's not a perfect outcome. This side looks pretty good, however. Now, this is peri-areolar surgery with just a keyhole. And this patient also had nipple reduction. And when I do a keyhole, I'm just making a partial incision at the edge of the areola. And then I can also do a nipple reduction at the same time. So before and after, and really you don't see much of a scar at all. Here's another patient with just a keyhole, before, after. These arrows are pointing to some fat, which is in the pre-axillary region, which I have done liposuction on. So you can see that fullness there, and now there is less tissue there. Here's another peri via a keyhole approach. All right, this is 3 years later, and the patient has done a lot of working out and has really built up the musculature. And you can see what an excellent result it is. Here's another peri with a keyhole result approach and also nipple reduction. Now, when I talk about my double incision procedures with nipple grafting, typically it's in patients with C or D cups or larger. They have inelastic skin and they usually have an asymmetric nipple position. All patients get liposuction in the center, in the pre-axillary region, and also on the sides. And you can see this patient is quite large. During the procedure, I will harvest a nipple and an areolar graft. I will then get rid of all the tissue, and I apologize for these gory pictures. Sometimes I take not the nipple and areolar as one piece, but a separate areolar graft and then a separate nipple graft. This is the patient on the table. I have done the mastectomy and closed the incisions, and now I am measuring the patient and drawing marks for where the nipple grafts should be located. This is an example of the graft within a graft nipple technique. I've put the areolar graft on the patient. I've cut out a little central defect, and now I'm going to apply the central nipple graft into that cutout defect. Here's what the patient looks like on the table when the dressings have been applied. Here are some before and after incision results. With my DI, I used to, way back when, do straight incision. So you can see before and after, and you can see that the incision is straight. There's excellent take of the grafts. Here's that patient you saw already, pre and then post. Note that the patient also started on testosterone, so that now there's a lot of hair growth as well. And you can see that the incision is straight and it's hidden mostly in the hair, and that there's excellent take of the grafts. Here's that other patient again, quite large, pre, post, straight line incision. Patient has started on testosterone, has also started working out, and now has better musculature. Around 10 years ago, I started curving up my incision. So if you look back, you can see this straight incision, right? And you can see that that's somewhat visible. I started curving up my incision to fall within the shadow of the pectoralis major muscle. So you can see this patient is pre. And now look, the incisions go around and they curve up so that they fall within the shadow of the muscle, and it looks more natural. And there's an excellent great take of the nipple grafts. Another patient, pre, post, the incision, look, if it was straight, you would see it there, but instead it curves up. This patient has done a lot of bodybuilding and has built up the muscle so that now you don't see the incision. And again, excellent take of the grafts. Pre, post, here's the incision, and you can see again that it falls in the shadow of the pectoralis muscle. Now that same patient is very interesting because look, this is him at 1 week. You can see the bruising and the steri-strip still applied. This is him at about 3 weeks, and then 6 weeks, and then here he is at a year. And you can see the evolution of the scars over time. Here's another patient at about 3 weeks, still with some antibiotic ointment on the scars. And here he is years later. The scars have turned white. They're much less visible. I also do more than just chest surgery. So sometimes my patients come in and they want complete body contouring. So here's a patient who I did a DI on, and you can see again an angled incision. Excellent take of the nipple grafts. But I also did liposuction and a lower abdominoplasty to contour the abdomen. And so now you can see a much more masculine appearing torso. Now, this patient has also worked out and lost weight and gained musculature. And I love it when my patients go the extra mile. Frequently, I get contacted by patients who have had top surgery from other practitioners. And some people out there are not so good at what they do. And here is one of my patients, and he contacted me. And you can see that there's all of this retained bunched up tissue. And there's these very, very bad looking nipple grafts. And so basically I had to redo the whole procedure and make the scar longer, get rid of all the extra tissue, and redo the nipple grafts. But you can see that that can make a huge difference in the final outcome. So that's hopefully not too long a demonstration of some of my before and after outcomes. Thank you for your time. Again, I live in Cleveland, Ohio. You can find more of my work at clevelandplasticsurgery.com. I'd be more than happy to evaluate any preoperative photos that you want to send in history, and would love to perform my operation on you if you choose to have me as your provider. Thanks again.